Okay, so we are going to be talking about the types of CHF here. Now, we have my handy dandy water bottle that I've used on the previous video that I told you had a fairly normal ejection fraction. So when we look at what normal for ejection fraction is, we see that our normal is anywhere from 70% to 55%. And you can see I've kind of drawn it out, how much the heart would eject anywhere from here down. Now, abnormal is anything below that 55% or anything above 70%. We actually don't want ejection fractions higher than 70. So now I've drawn out two more lines. So you can see the first set of lines is anywhere from that 55% down to 35%. And that would be mild to moderate. Okay, and then our final or severe CHF patients are going to have ejection fractions less than 35%. Now we also use the NYAH scale, so the New York Heart Association scale, to classify the different types of CHF. So we see that we might classify by the amount of dyspnea that a patient has. So dyspnea means that a patient is going to have difficulty breathing or shortness of breath. Now, we have two different types of dyspnea. We have dyspnea at rest and dyspnea upon exertion. So we'll see that a normal person, imagine if you're just sitting here, are you short of breath while you're sitting here watching this video? No. But if I were to ask you to go outside and run around your house 10 times, then you might have some shortness of breath. So we might see that a normal person is going to have dyspnea with exertion. But as our CHF gets worse, we're going to see that these patients are going to have dyspnea. So while they're sitting here watching the video, they would have dyspnea or shortness of breath just sitting there at rest. Okay. Now, there are two different types of hearts that we might see have congestive heart failure. We have a hypertrophied heart and a dilated heart. The hypertrophied heart is very much like a glass jar. So imagine hypertrophy of any muscle. So a muscle in your body, how do you gain muscle mass? By putting force against it. So if we see that the heart has a lot of pressure against it, maybe from some stenosis of an artery or lots of plaques in the artery, that the heart has to work harder to push blood against those arteries. That's going to hypertrophy the actual muscle of the heart. But we know the chamber inside doesn't change. It doesn't increase in space. So as the heart hypertrophies, the chamber inside gets smaller and smaller, and it ends up solid like a glass jar where it can't push against its own muscle wall. Our second type is a dilated heart. So normally we see a muscle is able to contract and relax, like this balloon. So I would blow it up, and if I let the air out, it would contract all the way back down. And I blow it up and contract and relax. Every muscle should be able to contract and relax. But we see that a dilated heart is like a balloon that's been left open for too long, or left blown up for too long. Now, your heart doesn't stay blown up for too long, but we see that when we don't have muscle fibers any longer, instead we have scar tissue, that scar tissue cannot recontract and turn back into this type of balloon. Instead, it stays overinflated here or dilated. So where do we get this scar tissue? Potentially from a previous MI or myocardial infarct, or any type of scarring to the heart tissue is going to create a heart that is more like this balloon, where it can't contract all the way and therefore can't push enough blood out to meet the needs and demands of the body.